really trailblazer in the whole area of juvenile myositis research through his position as a leading clinician at the Hospital for Sick Children in Toronto. Dr. Feldman is a clinician scientist and rheumatologist, and he sees children with arthritis and other rheumatic diseases. We funded Dr. Feldman and his colleagues over the years for any number of projects that are currently underway that have been under his leadership over the years, just added extraordinarily to the knowledge and improvement in treatments and care for JM children. So I'm happy to introduce him to you. Now be talking about exercise as therapy in juvenile myositis care, Dr. Brian Feldman.
Oh, thanks, Jim. It's a real pleasure for me to be here with you guys. I'm just going to share my screen now. Hopefully you can all see that just fine. Ryan and Shannon will be monitoring the chat, and maybe Suzanne too. So if anybody has any questions as I'm talking, please go ahead and put it in the chat, and I can either stop to answer it if you guys think it's appropriate, or we can answer them at the end. Now, I've talked to many of you before on this topic several years ago at one of our meetings. I think it might have been in Chicago or somewhere, talking about how life factors, things that we would normally think as being part of a healthy lifestyle, how they impact on children who have chronic myositis. And this all goes back, I told this story at the last time that I talked about it. It goes back to my dad's advice to me. My dad was a very famous pediatrician. He's passed away now, but he told me, there's 4 things you need to do to stay healthy for the rest of your life. One is get plenty of fresh air. I'm not going to be talking about that much in this talk, but I think it's probably very important. To get great sleep, do the proper amount of exercise, and eat a healthful diet. And so these are things that I've been very interested in seeing whether, in fact, they make a difference for our children with chronic illnesses. And because of my special interest in myositis and children with dermatomyositis and other types of chronic myositis. So let's start with exercise. Now, I think all of us feel that exercise is an important and good thing to do, but traditionally exercise was seen as being potentially harmful for kids with myositis because the muscles were inflamed. There's been a lot of work since then. Even though we think exercise is a really wonderful thing to do, what does the science tell us? And is there any science to support this? The reason why we think exercise is particularly helpful for children with myositis is because of these kind of relationships that I've drawn here with these lines. So kids who have muscle inflammation and pain or muscle damage end up with muscles that don't function as well. They have dysfunction of their muscles. And because of that, they probably limit, and you've seen this with your own children or your grandchildren, they limit the activities that they take part in compared to their siblings or their other classmates. That leads to deconditioning, and deconditioning leads to further activity limitation. Activity limitation itself might lead to more inflammation and pain in the muscles, more muscle dysfunction, and certainly being deconditioned restricts our ability to participate in the normal things that we do in childhood, leading to further deconditioning and further restrictions. And exercise is seen as a way of potentially breaking this cycle and maybe working at many different areas. So are kids with dermatomyositis deconditioned? Well, I think now there's lots of evidence. There's studies from Holland, or the Netherlands, if you like, from the US, from Brazil, that really document that children with dermatomyositis at various stages in their illness are poorly conditioned, are unable to exercise as well as other kids their age or their siblings, things like that. But what's more important, and certainly more important to me, is that these deficiencies persist even in those kids whose dermatomyositis gets all better, whether they're on or off medication. There's been a number of studies now to show that over the long term, the damage that occurs from myositis when you're young can lead to being less fit and less active as you get older into adulthood. And again, studies from Norway, from other Scandinavian areas, from Utrecht in the Netherlands, have demonstrated this really in the long term. In kids with active myositis, or at least with myositis that are on therapy, there is probably evidence that exercise training can help out in the short term. Marco van Brussel is a colleague, an exercise scientist in Holland in the Utrecht, and his student, Esther Habers, for her PhD, did the muscles in motion study. Now, this was a comparative trial, randomized trial, to look at children and adolescents who had myositis and compare them, and within them, compare those who went into an exercise program that was a program of interval aerobic training, so cardio training and strength training, to kids who were on a weightless control who didn't exercise. And what they found at the end of their study is that, at least in the short term, exercise is safe. So our previous concerns that it's going to harm the muscles were wrong, that kids will do it. You could set up these exercise programs, they will do it. And even though their primary outcome measure for this clinical trial, that is the thing they were thinking would change the most, which is how fit they were on an exercise test, didn't really change. The kids in the exercise group did better on push-ups, they did better on sit-ups, they did better in jumping. And for those of you who do this in clinic, the Childhood Health Assessment Questionnaire, or the CHAQ, or the CHAQ, is a questionnaire that looks at how active you are and what activities you're able to do with myositis. And it improved in the kids who exercised compared to those who didn't. So exercise training seems to be a benefit, at least in the short term. And when we look at those children who have recovered from their dermatomyositis, and they're now older teenagers or young adults who have poor fitness, exercise training from this study in Denmark shows that you can improve your fitness training just the same way you could if you were deconditioned and a healthy person. So there's nothing about dermatomyositis that says you can't make it better by exercising. What I'm showing you in the bar graph here is before and after 12 weeks of cardio training, what happened to how efficient the lungs were at bringing oxygen into the body and into the muscles. That's the VO2 max. That's on the vertical axis. And before training is in black, after training is in gray. And you can see there was quite a big improvement with endurance training in these people who had deficits long after the dermatomyositis was in remission. So I think we can say, with the data that's currently available, that it's pretty strongly suggested that both in the short term and in the long term, exercise is going to make you better, more functional, and more fit, even if you have dermatomyositis. Now, what about sleep? I never really thought about sleep very much. And, as a doctor, we used to think, well, if I can get 5.5 hours of sleep a night, I'm golden, I'm great, I can get that much more work done. But one of my trainees a number of years ago, Yanni Butbul, who's now in Haifa in Israel, was very interested in sleep and sleep research. And so I wanted to support him. So we said, okay, let's study. We'll give a questionnaire to our patients. We did this both with arthritis and with dermatomyositis, and look at using validated questionnaires about sleep quality, as well as questionnaires about fatigue during the day, pain, and quality of life. We said, let's just see what happens in these disorders. Sleep is a problem. And in fact, it was. A great majority of our patients had disordered sleep and dysregulated sleep with nighttime awakenings and all kinds of sleep problems. And the quality of the sleep was strongly related. What I'm showing you here are correlation values. 0 would be no relationship. 1 would be perfectly related. And what you're seeing there is that the better sleep you have, the less fatigue you have. That's a strong correlation of 0.45. The less sleep you have, the more pain you have. That's quite a good correlation. And the better sleep you have, the better your quality of life is. again, with quite a strong correlation. Now, of course, we never know the direction of how this works. It may be that because you have more muscle pain, you don't sleep as well. All we could show here is that these things were connected. So we did a study that I would love to do in kids with dermatomyositis. Dermatomyositis being such a rare condition, we would have to do this probably across North America. So we did this instead with the other group that we studied, kids with arthritis. And what we did is we had kids, we bribed kids to sleep longer for a week and then to sleep shorter for a week. And we measured their pain and other things in both the long sleep week and the short sleep week. The short sleep week was kind of average for a lot of teenagers in Canada, about 6.5 hours. And we, in the long sleep week, bribed them to sleep for 9 hours. Now, this was a randomized trial. So some kids did the long sleep week first and the short sleep week second, and vice versa. And what we found, this paper is just being submitted for publication, but this was a poster that we presented in Prague at the European Pediatric Rheumatology meeting. What we showed is that there's a good and very strongly statistically significant relationship between getting more sleep and having less pain if you have arthritis. Suzanne, I see you. I'll get to you in a second, even though nobody else has told me that you're there, but I can see you. In this particular study, remember that the difficulty is we didn't know which came first. Is it pain or sleep? And it may be that pain leads to poor sleep, but what we showed is that sleep causally relates to less pain. You sleep better, you can have less pain if you have arthritis. And I suspect that's going to be true this was also true for fatigue and for all the other things we looked at, that this would be true for kids with dermatomyositis too. And the only way we got them to sleep more is we just bribed them, put away their phones earlier and get to sleep longer. And we just gave them rewards for doing that. So my takeaway from this is that sleep is also very important for kids with chronic illness. This has been studied in lots of other chronic illnesses and also equally important. And I'd love to do this study in kids with myositis. Suzanne, what were you going to ask?
So my question is disordered sleep also related to steroid use? And if so, how do you help kids with that particular issue?
So disordered sleep has probably got a lot of different factors in kids with dermatomyositis. Medications is undoubtedly one of them. I think everybody at the beginning, when you're on a high dose of corticosteroids, almost every child will have problems with sleeping with that. And every time the dose goes up, the sleep gets worse. I hear that from just about every family. Methotrexate probably also disturbs sleep as well. But the dermatomyositis itself produces chemicals in the body that float around that we know about that also seem to disturb sleep. Things like interferon, tumor necrosis factor. Those things make our body feel, and you may hear this from your kids or your grandkids, make our body feel like we've got a terrible virus, except it's always ongoing. And as you know, when you have a terrible virus, you don't sleep well. You may sleep a lot, but you don't sleep with good quality. So there's lots of reasons why in dermatomyositis your sleep may be thrown off. And then the real thing is to optimize what we call sleep hygiene and to make sure you're doing all those tricks that you can do to get as good a quality sleep as you possibly can and sleep longer. That was true for the kids with arthritis too, right? They were on medications. They had all these chemicals floating around, similar ones to dermatomyositis. And all we needed to do was to really, like I say, reward them for sleeping longer. And they did it, and it made a difference to them. So I would say sleep should be a big target as much as we possibly can for kids who are very motivated to stay up all night on TikTok and chatting with their friends. Okay, the next thing I want to talk about is diet. And diet is much more complicated. In fact, I would say it's super complicated. One of the ways we understand how diet may impact on dermatomyositis in children is its relationship with what's called the microbiome. I'm sure many of you have heard about the microbiome before. The microbiome is the trillions and trillions of germs that live on our body and in our body. And one of the most important areas for all these germs is inside our stomach and intestines. there's more germs in our body than there are human body cells. And these germs sit inside, for example, our gut, our intestines, and our stomach, and they make chemicals. They eat food and they excrete chemicals. And those chemicals could either be beneficial, that is, they can reduce inflammation and make us feel better, or they could be harmful. They can increase inflammation and make us feel worse. And the idea behind diet that I think is most widely accepted now is that if you eat the right foods, healthful foods, that it will impact the germs in your body to produce good chemicals. And if you eat the wrong foods, that is unhealthy foods, that you're going to grow up the wrong germs in your body that are going to make the wrong chemicals that are going to make you feel worse. Now, I've got two pictures here about what are the right foods and the wrong foods, but of course, we don't know what the right foods are or the wrong foods, and especially because the germs in our body, the composition is as unique to each person as our fingerprint. The germs in our body are as unique to each person as our fingerprint. And so what might be a healthy food for one person might not be a healthy food for another, and vice versa. So even though I've drawn some pictures there, like super delicious things that could be good or bad, it's not clear that for any one person, those things would be good or bad. And that's why no particular diet for any of the conditions that we look after, including dermatomyositis, has ever really come out as a clear winner. However, what seems to be super important, is to do what you can to increase the number of different types of germs in your body, especially in your gut, so that there's a good influence of all the different types of chemicals and a good balance that will allow you to maintain a healthy life. And the way to increase the number of germs, the number of different types of germs in your body that grow up, that is, you're not all just the bad germs, is to eat a diet that's got lots of fruits and vegetables, lots of whole grains, and you can have meat. There's nothing wrong with meat, but limited amounts of processed foods. And that things that are like highly processed starches and sugars tend to grow up nasty germs that produce bad chemicals. Now tell that to a teenager who all they want to eat is donuts and French fries. That's a difficult thing. However, we are studying this now. We've just started a study in kids with arthritis. Again, it's easier to study with arthritis because there's many, many more patients. So to do a study like this, it's a study I would love to do in myositis. And in this study, we're going to look at something that's quite similar to the Mediterranean diet, lots of fruits and veggies, lots of whole grains, limited amounts of red meat, low processed foods, and we'll see how it affects the germs in the body and how that affects the kid's arthritis. I would love to do that study in dermatomyositis too. For those of you who are just really interested in diet, this guy, Tim Spector, is like a super genius scientist from the UK. He's published over 1,000 papers, and he's one of the most influential scientists of our time. And he's written a bunch of books about diet. He's a geneticist, but he became super interested in the genetics of the microbiome and in diet. And here's a couple of good books. I didn't read The Food for Life. That's a new one. I'm going to get it and read it. But I read Spoon Fed, and it's really good because it just kind of trashes all the stuff that you read about in the on the internet or in magazines or all these food fads, and really goes into the science, but in an easy to read way. So I think those are two good books. Certainly Spoon Fed is a good book if you just want to kind of find out what do we know about diet in 2023. Now, what we've been studying is a little bit simpler. What we've been looking at is the role of supplements in kids with dermatomyositis. And this goes back to an understanding that's been around for well over 20 years, that the weakness that we have in dermatomyositis as a result of the inflammation largely has to do with a poor supply of energy in the muscle. And I'm going to explain that. Basically, and you may have heard this from other folks, dermatomyositis is at its core a blood vessel problem. The body has inflammations. It's like a chronic viral infection, even though there's no virus. And all those chemicals inflame and upset the tiny blood vessels that supply oxygen and food to our organs and our skin and our muscle. Those blood vessels that aren't supplying enough oxygen and nutrients to our muscles lead to the energy problem. Inside our muscles, and I don't know if you can see my pointer, but this thing on the bottom here is a picture of inside a muscle cell, a little structure. We have lots of these in every muscle cell called the mitochondria. Mitochondria are very cool. They're like little batteries or little power plants, more like generators, little power plants that provide the energy in all of our body, but especially in muscle, in order for our muscle to work well, to bend and lift things. Inside the mitochondria, this is what happens. We have a molecule. Now, look at the blue one at the bottom. That's called adenosine triphosphate. That's an adenosine molecule, that's the blue part, with 3 little phosphates on it. Those phosphates are bound to the adenosine with a very strong, think about it like a strong magnetic binding. And in our body, when we peel one of those phosphates away, it releases a burst of energy. So when we take one of the phosphates away from ATP, that's adenosine triphosphate, it gives a bunch of energy for a muscle contraction. But what you're left with is ADP. That's the adenosine. This now it looks yellow with only 2 phosphates on it. This is happening in the mitochondria. And in order to replenish our energy supply, we have to take some more of this phosphate that's floating around and bind it back up to the ADP to make some more ATP. That is, add energy back to the molecule so that we can have another muscle contraction. Phosphate, in order to get onto ADP, needs to be bound to something called creatine. Now, any of you who is into sports, many people who've been to a supplement store will have heard of creatine. Every athlete that's highly competitive tries to stack their body full of creatine so that they can make this process go more smoothly. If you got more creatine, more of this phosphate that's floating around will bind to this molecule that's necessary to regenerate the energy molecule, that ATP. So that's pretty cool. If you get more creatine, maybe you could have more energy in your muscle, and maybe that could happen in dermatomyositis. And we know that that works for other muscle diseases. So this is what's called a meta-analysis. This is a combination of 4 comparative studies where creatine in kids with muscular dystrophy was compared to placebo. And this little diagram on the bottom right of the slide shows the 4 studies with what they found in blue. And then when you put them all together, you get that gray diamond. And what it's basically saying is that the global muscle improvement in the muscular dystrophies improves like 6 times. It's close to it's like 5 times if you take creatine compared to if you take placebo. And this seems to work, at least in one study, in adults who have myositis. So in a double-blind, randomized, placebo-controlled trial, meaning that patients didn't know what they were getting. They went for 6 months, either getting creatine or placebo. Now, in this particular study, I should say, they also all got an exercise program. So they were exercising, and they either got placebo or they got creatine, that the amount of free phosphate and the change in the energy ratios after 6 months, you see that on the bottom here, was much better in the creatine group than it was in the placebo group. At 3 months, the placebo group actually got worse. But when it was studied in kids with dermatomyositis, by a nice study from our colleagues in Sao Paulo, it didn't seem to work. So we went ahead and studied again. in a slightly different way in Toronto. So this was our study that was published a couple of years ago, looking at creatine supplementation on how kids did with muscle. I'm going to explain it in just a few slides. So we took 13 children with dermatomyositis. These are fairly stable kids on stable medication. So it's more like that long-term problem that I'm talking about. This wasn't something we did at the beginning when they were on high doses of prednisone. They were all between the ages of 7 and 18, because we don't see kids after they're 18, and you had to be about 7 to be able to fit on the exercise bike. Anything younger than that, you're too short to reach the pedals. And what we did is we measured every month a whole bunch of different tests. We did something called a Wingate test, which I kind of love. That's the one in the middle picture there, where the kids pedal as fast as they possibly can for 30 seconds, and we measure how much energy they're able to produce in their pedaling. We looked at how well they jumped, how strong their hands were. We looked at just their disease activity. Quality of my life, that's a QOML, is just an overall quality of life questionnaire. And Pete's QL fatigue module is how much fatigue they had. We looked at how satisfied they were with all this creatine they had to take, and how active they were. And we put the kids in an MRI machine. That's the picture on the left. And we had them cycle using this non-magnetic cycle in the magnetic resonance machine to see how well their muscles were using energy. Now, what we found was that the creatine was well tolerated. Like, the kids took their creatine, didn't seem to have any problems, there were no side effects, but it didn't really change how much the kids were able to do. That's similar to the Brazilian study. But what we did notice is that in the MRI, the muscle energetics did get better. I'm not going to go through the diagram there, but what we found is that they were better able to make that ATP when they took the creatine, so that worked. That there was less phosphate floating around, and more of it was bound up to the phosphocreatine, that CP that I showed you in the diagram, so it was more available for energy. There was less metabolic stress during exercise, and they just made more ATP in total. So the muscle energetics did improve based on our MRI findings. So that led us to the study that we're almost finished doing, that's been funded by CureJM. The thing that was different between the Brazilian study and our study and the adult study was the adults also had an exercise program. So maybe part of the reason why the creatine worked better was because they were exercising. So in our study that we're doing now, the idea is to creatine, and to the creatine, we've added another medicine that you see in supplement stores that really works on the mitochondria, those little power plants, to help heal them up and give them more energy, called coenzyme Q10. And if we add it to increased physical activity, does that lead to better muscle power and better functional outcomes? The way we're doing this study is we have used a table of random numbers, and every child in the study starts off taking something, but we don't know if it's the placebo creatine and coenzyme Q or the real placebo and coenzyme Q. And then based on that table of random numbers, they go along, we see them every month, we study their strength, and at some point before the end of the study, they all will end up on the active creatine and coenzyme Q. And what we're looking for is to see is when they go on the active stuff, they don't know and we don't know because it's all identical stuff, is there a change in their exercise testing, what we notice in our clinic visit, and their questionnaire, similar to the previous study. Now, the physical activity for this particular study is we tried to do something individual for each patient. So it involves coaching using something called SMART goals. We measure their physical activity. Everybody gets a Fitbit for the 6 months of the study, and we're tracking their steps and their activities. And they also have an app called the Atomic app on their phones. If they don't have a phone, we give them a phone for the study, where the coach can interact with them on a regular basis. There's all kinds of goal setting and educational things as part of the Atomic app. And with this, we're getting the kids to be more active than they were before while we're going through this study, seeing if the supplements add on to that activity. Now, where are we at? So we approached almost 40 patients so far. Not surprisingly, Not everybody wants to come in every month to do an exercise test or to take a bunch of supplements. So 18 patients declined, 3 are still undecided. 18 consented, but 4, after they got there and saw what the exercise testing was all about, decided not to continue any further. 14 patients have started the study. Of those 14, 8 are finished. 2 more withdrew. 4 are ongoing. They're likely to finish. And we had said we would enroll 15 patients altogether so that we finish with 12. If we finish with 12, we should have enough to understand how well this works. We'll probably finish with 12 without that last one to enroll, but we said we were going to enroll 15, so we're going to do it. So this study, because of the pandemic, has taken, well, 2.5 years longer than we thought it would, but because we couldn't enroll during the pandemic, but we're getting close to the end. So thank you, CureJM, for that. So where are we at? Well, we didn't really talk about fresh air. I think fresh air is probably super important. It's been studied in all kinds of things, but not in chronic illnesses of children. Sleep is for sure important. Exercise, probably important. It's certainly very safe, probably important in the long term. We're not really sure yet about diet. It makes sense. There's lots of reasons to think it would work, but we don't know for sure. The science has to be done to be very confident about it. But I think the idea here is that if we follow good lifestyle strategies, it's safe and helpful for our kids on top of the medications that they have to take. None of these things are powerful enough of a disorder like dermatomyositis to replace medications completely, but maybe they're enough so that we don't need to take as much medicine. Anyways, that's all I wanted to talk about. And then what I thought is we could spend the rest of the time taking questions.
Thank you, Dr. Feldman. That was a wonderful presentation. Couple of things before we get into the Q&A. For everyone on the call that would like to stay after the Q&A portion, we will be breaking out into rooms for parents, teens, patients, grandparents. So stick around following the Q&A if you would like to join us for a brief social time. And with that, we would invite anyone to submit questions for Dr. Feldman via the chat or raise your hand.
And Ryan, will you decide which questions we do first?
Absolutely. We can go based on chat. I think we addressed Suzanne's first question. Shannon, do you have one?
Yeah, I had one that came up from someone who said they couldn't attend, Dr. Feldman. But I told them a little bit about what you were doing, and we will send them the recording. The question for them was, for the children in your study, are they also on the same kinds of typical medications that our children are on? And would there be any concerns on your side, knowing that you might be on methotrexate or prednisone or IVIG or any of the other medications with how it would interact with those supplements?
So the kids in our study are all on stable medications. And at my center in Toronto, we try and really reduce the use of prednisone. So most kids are off prednisone by about 9 or 10 months. That's different in some centers. So kids stay on prednisone for longer. And so we don't have anybody on prednisone in our study, but we have a number of the kids are on methotrexate and intravenous immunoglobulin. In fact, it's a little easier because they're coming in every month for the IVIG. So they just come in and do their exercise study. We figured out a way that we could get it all done in the same day. So some of those kids were the ones most likely to come in. We have some kids who are also taking mycophenolate mofetil. In this study, I don't have anybody who's taking tofacitinib or baricitinib or anything like that. But yeah, no concern with these supplements and the medications that we take with dermatomyositis.
Great.
Looks like we have one coming in. Are you correlating meds with exercise improvement?
So again, the medications are stable for the whole study, and there's only going to be probably 12 or 13 patients analyzed at the end. So it's going to be a little hard since just about everybody in the study is on the same medicines. It's going to be a little hard to determine how medicine impacts with improvement as it relates to exercise. that's the kind of study that we could do with, if we got a whole bunch of centers together and got a bunch of Fitbits out there and just measured everybody's activity. But that kind of study requires large numbers of subjects and wouldn't be possible to do within this project, which is why we kept medication stable in everybody. We didn't want to take anybody who's on changing medicines.
Mm-hmm.
Thank you. And we have one that came in from Debbie Dom. Are there any particular types of exercise that are more or less beneficial? Examples would be yoga versus tennis.
It's a little hard to say for dermatomyositis because it hasn't been studied that way. I'll tell you what we did in a study of children with juvenile arthritis is we did a study comparing something like Tai Chi, it was called Qigong, and compared it to cardio karate. So the difference between the two of them was the cardio exercise. So one group got cardio exercise, the other group got weight-bearing, balance-based exercise, but no cardio. And we also did the same study in kids with fibromyalgia. And it turns out the cardio component is really important for some of the things we want to look at. Now, the kids loved the Qigong. Like, there was nothing wrong with it. The Tai Chi yoga exercise was very valuable for them. They loved it. They didn't improve in the health measures that we would normally look at. The ones who improved in the health measures were the ones who got the cardio exercise. Other folks, although it's been reported but not well published, have looked at strengthening exercises in kids with arthritis, not in, the only study in dermatomyositis is that one that I showed you, and suggests that strengthening may work well for some of the health outcomes in arthritis. The muscles in motion study, the one that we talked about earlier from Esther Habers, looked at a combination, right? It was interval cardio training and some strengthening exercises, and that combination seemed to work well in their studies. Some of the outcomes that improved the most were the strengthening ones. I think not sitting down all day long playing video games and getting on your phone is probably the best thing we can do, and that's more the focus in our current study, which is we're whatever the kids want to do, we're coaching them to do it. We're not saying you have to do this particular type of exercise.
Dr. Feldman, I think this is a bit of a personal one that I touched on with you when we first spoke. Do you feel like most physicians, prescribe or view exercise at this point as an actual prescribed treatment versus just, physical therapy that kind of has an endpoint?
So I think what happens because of the availability and the kinds of resources that are available varies from clinic to clinic and center to center. I think the philosophy of the physiotherapists that work with the medical teams also vary considerably from center to center. So for example, if you have dermatomyositis, and at least up until recently, you were seen in London in the UK at Great Ormond Street Hospital, you'd be admitted for weeks of intensive physiotherapy and exercise therapy. And they seem to think that that's a great value. Most places can't do that, right? Most families can't afford that. Most insurance plans wouldn't pay for that. The reason we got so into fitness exercise, and I was talking about this with Brian earlier in the week, is that the physiotherapist, a very famous arthritis physiotherapist that I worked with when I was just starting my career, already in the late 80s and early 90s, had the belief that the best way to go for kids with rheumatic diseases was to get them to do more fitness and play types of exercises rather than structured, strengthening and range of motion exercises. So that's what got us into this right from the beginning, was just Virginia's way of thinking about it, what the conclusion she had come to at that point. And she in her own right is quite a famous scientist and physiotherapist. So I think that's probably depends more than anything else, because there's certainly a role for all kinds of physiotherapy, especially early on in kids with dermatomyositis and other forms of myositis.
And hey, Ryan, one other question that had come in from a member of our fundraising team who couldn't attend. I think you alluded to this, Dr. Feldman, but just to make sure we understood you correctly, is it possible that benefits from exercise and those kinds of benefits that you were talking about might allow a child to decrease their medication. So could starting an exercise routine provide a therapy that might, for a child who's taking the chronic medications, to kind of reduce some of those over time? Has anyone researched that?
So that hasn't been researched. I have to say I'd be a bit doubtful that exercise would allow us to reduce medications. However, if anything's going to do it, I bet you increased sleep and an improved diet would decrease the actual inflammation and allow us to reduce the inflammation medicines. And that being said, there's some kids, there's such a variety in the kids that present with myositis. There's some kids that do everything they can to sleep well. They exercise as much as they can. They have the best diets in the world, and they have a horribly resistant type of dermatomyositis that requires a lot of treatment. And then there's other kids who you don't have to hardly do anything, and they just get better and it just goes away. So just like I was saying, that the whole issue of diet it's like a unique fingerprint for each person. I think dermatomyositis is a little bit unique for each person. And we don't yet have the tools and the understanding of the immune system that allow us to say for any one person, what's the best treatment and what's the course they're going to follow. We're getting there though. And some of that work's being funded by CureJM. Like we're getting all these fantastic precision medicine tools. They're just not quite there yet.
Great, thank you. Looks like we have another one through the chat. What are your thoughts on resistance training as well as weightlifting for newly diagnosed kids?
So one of the things that I think really put my mind at ease was a study that was done in London in the UK by Susan Mayard and her team that took kids with new dermatomyositis, gave them resistance training, and then put them in an MRI to see if there was any damage to the muscles, and there wasn't. So I think it's safe to do that. I'm not sure how helpful it is until there's been some healing in the muscle tissue, because when there's a lot of inflammation and there's a poor blood supply, you may not get the kinds of benefits that you would get otherwise. But almost, if you're really weak, anything you do is resistance training, isn't it? Like getting up off the ground, walking, getting out of a chair, that's resistance training. And so the nice thing is it's safe. And yes, Sue Maillard is the UK physiotherapist that I just mentioned.
So one of the biggest takeaways, it sounds like, Dr. Feldman, is that regardless of how bad a flare may be or disease activity is, physically it's safe, on day one to start with exercise, whether it be physiotherapy or whatever your body's allowing you to do, it is safe.
I think that's well believed across the community now. It's like anything else, too much exercise is going to lead to injury. That would happen if you're perfectly healthy. And so you have to be smart about it. And the best way to do it is to trust your kids or your grandkids and let them know when it's too much to stop. Because you certainly don't want to make things worse, right? Anything that we do, it's like giving medicines. You don't want to make things worse. You just want to make things better.
Finding the balance. If kids feel too weak, what about swimming? Taking some resistance off, it sounds like.
We use a lot of water-based exercise in our program. I think it's a fantastic way when you're, because the water supports you, right? When you're weak, to either go swimming, or if you can't swim, to do water-based water aerobics and things like that. Those are great exercises. They're also great if you happen to have a lot of pain. If you have arthritis, say, or if you have a lot of muscle pain, it's a lot gentler than pounding on your joints in the kind of high impact exercise that some of us do. Now, water aerobics has been studied with kids with arthritis and shown to be beneficial.
Great. Does anyone else have any questions that they want to raise their hand for or submit while we have Dr. Feldman?
So it's kind of interesting that all the questions have been about exercise, because I normally get way more questions about diet from folks.
I think you did a good job disclaiming how complicated it is, maybe.
I
We
will
have
say
one
that
coming
we
from
get-
Randy.
Oh, go ahead.
Totally agree with Dr. Feldman's comments. Swimming was started with my granddaughter shortly after diagnosis at 5 and very helpful. At 16, she swims in the high school swim team. So more of a comment from Randy on the effectiveness of swimming.
And if you
Yeah.
think about the studies that I showed about the long-term effects on some people, that's a great endorsement, isn't it? That if you stay active and you keep working, you'll heal up those muscles that much better, keep those blood vessels, they'll regrow, get more energy into your muscles, and you can still be very athletic, despite the fact that you had a disorder that for other people might last well into adulthood.
Mm-hmm.
Dr. Feldman, I would like to say that we get questions about diet, or people are asking each other about diet all the time. So I would love to see a study that includes JM kids with various and sundry diets. I think that would be an incredible project for us to help fund.
Now, unfortunately, Suzanne, the budget for our arthritis study, just for the small pilot study, is several $100,000. And like this, these are fairly expensive things to do, to provide people with different types of meals and do the kinds of checks that we need to do about what's going on in their germs. So I'm not sure this is within the range of Cure JM funding, but with NIH partnership, this is the kind of study that could be done across, say, one of our networks like CARA.
Mhm.
And I'd love to see this happen. I think we just took years, but we got the arthritis study off the ground. And if there's a push and a will, I think it could happen.
Yeah, and I thought it was interesting too, Dr. Feldman, and maybe we could get some of the papers that you cited. We've been treated at probably 10 different centers and clinics, and I've rarely heard anyone except you talk about sleep, and it seems like it's very important. So that might be something that our parents might be interested in learning more about as well. So I really appreciated that.
How did you end up at 10 different centers?
We moved 3 times because my husband wanted to work for a startup, and then before we had to fly to see Lauren and Lisa, wherever they're located at the time. But it's just not too often that you hear about sleep, is it?
I would have completely ignored it up until the early 2000s, till I met Dr. Blitbull. I just wouldn't have thought about it, but clearly very, very important.
Yeah.
Well, thank you very much, Dr. Feldman, for a incredible presentation and kind of showing us the full picture of not just exercise, but the other pieces of healthy living that may play an important role in JDM. At this time, if there's no other questions, I'd like to hand it off to Jim for closing remarks. And again, if there's anyone that would like to stay on for our social breakouts, we will do that here shortly. So Jim, over to you.
All right. Well, thank you, Dr. Feldman. Appreciate it. As always, your leadership in research, both across the United States and internationally, has been just most helpful to our families now and over the years. So thank you very much. I think we're all going to run out and buy that book from Tim Spector on spoon-fed, and maybe that will prompt us to start looking at funding some diet studies. I think to sort of echo what Suzanne said, that would be something we'd be very interested in at least looking at in partnership with CARA and others. Again, just to remind all of our families about our annual conference coming up at the end of June 29th to July 2nd, and Walk Strong Across America, Walk Strong from Home, very important projects for us to allow us to continue to fund these kinds of studies of benefit to our children.